Good afternoon, everyone. This is Brian Robson, the Medical Director at Healthcare Improvement Scotland, and welcome to this, the sixth in our exciting lineup of QI Connect sessions for 2017. In fact, the 36th since the series began. QI Connect provides an opportunity for colleagues across health, social care and beyond to learn from international leaders in the field of improvement, innovation and integration. We've designed these sessions to be short, accessible and recorded to allow access at a time that suits you. I'm now going to pass you over to Jennifer, who will tell you a little bit more about the session and the technology we're going to use. Good afternoon, Jennifer.
Thanks, Brian, and good afternoon, everyone, and welcome to today's session. So I just have a couple of quick housekeeping slides just to get us started. If you can please use the chat function you see on the right-hand side of your screen to communicate, and I'll talk you through this in just a moment. If you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the events manager using the chat function or by pressing *0 on your telephone keypad. So these sessions are designed to be a fun, interactive learning experience. So we do encourage you to use the chat function and to share any questions, comments or ideas throughout the talk. There will be an opportunity for Q&A at the end of the session. And we will also be sharing hyperlinks within the chat function to any resources mentioned by our speaker today. And of course, please do feel free to share any resources that you are also aware of. So we did promise that today's session would be fun and interactive, so now is the interactive part. We're keen to find out where you're joining us from today. So if you could please use the annotation tool that you see circled in red on your screen. So just the top left-hand side of your screen, it looks like a pen. And then click on the arrow icon. You can also see down the left-hand side. And click on your location.
Wow.
Lots of colleagues joining from the UK today, so welcome everyone.
Yeah.
There's a few.
Great to see Gisela, Colleen and Wanda from over in sunny Canada. Wow, we've overloaded the UK, it's tipping up. And it's great to see the chat box with people saying hello on the chat box as well. Thank you, Jennifer. Thanks for that introduction, and great to see so many names, including Barbara, who's currently swimming the Atlantic. Oh, you're making it across to the US. Welcome, Barbara. Thanks very much, Jennifer, and we're always delighted to shout out how the reach of QI Connect, and we're extremely delighted to break through the 600 organisations barrier. So we've now got more than 600 organisations signing up for QI Connect, and we'll hear more about them just in a moment. But before we go further ahead, let's go to the competitions and let you go back to your arrows. We're always delighted to shout out the number of countries, and indeed we're a record-breaking 52 countries connecting in with QI Connect. So 608 organisations, 52 countries. I think QI Connect's living up to its name. So for the competition, I'm going to shout out the name of the latest country, and if you can get the first one to put their arrow on the latest country will in fact win an amazing prize. So the new country to QI Connect is Sri Lanka. Oh, Stuart Japp. And Stuart Japp, well done, Stuart. That was pretty quick. Everyone else is doing really well. Tom Gibson, well done, Tom. Good to see Maureen's on the case as well. However, we're delighted that Stuart, who's a medical education coordinator in NHS Dumfries and Galloway's, was first on the buzzer. So well done, Stuart. And you win an QI Connect mug, much sought after QI Connect mug. Well done, Stuart. And just a shout out to all of the organisations. We've now got 18 pages of organisations' wonderful logos from all over the world, from 52 countries, from 608 organisations, which is absolutely amazing. And great to see so many international logos on on the QI Connect screen. Such wonderful, wonderful connections. And we're always keen to shout out the whole of NHS Scotland that signs up for QI Connect. So an international, a global community, and everyone here in Scotland connecting in. But absolutely delighted to shout out the universities that join QI Connect. And in fact, we have a new university for the very first time, and the new university is from Qatar. It's the Al Khor Qatar Academy, so you're very welcome to join us here. That brings the university's total to 57 universities across 52 countries and 608 organisations. So you're very welcome to join us from Qatar. And for the first time also, we've got some other new organisations joining us, as well as our new university. So we've got an impressive 26 new organisations joining us there, from Australia, from Qatar, from England, from Alberta over in Canada, from IBM. Delighted to see so many new organisations. You're very, very welcome. And just to remind everyone that with the medium of WebEx, we're recording the session so that these sessions can be used time and time again. They're free for you to download and use. And this initiative was started by our friends in Koawatea in Counties Manukau in New Zealand. And this is them in one of their learning sessions a couple of years ago. So please consider using the downloadable sessions to learn more again and again with QI Connect. And as I say, all of these sessions are available for free download from the Healthcare Improvement Scotland site. And we know that these resources are used routinely as part of the International Society for Quality in Healthcare's fellowship programme. And we also know that QI Connect Resources is now in a new partnership with the Health Foundation and NHS Improvement through the Q initiative. And delighted to have so many Q members from across the UK supporting, joining and spreading the word about QI Connect. Delighted to have that partnership up and running in 2017. And just a quick shout out to the small but perfectly formed QI Connect team. You've heard from Jennifer. We have Carmen Forrest, who does all the administration and indeed provides your certificate of attendance and registration after the event. We have Michelle De Felici, who's also doing registration and running the session here with us today. And we have Alex Sterling with us here in the studio on Twitter. And we're joined today by Jill Patterson also, who is a Clinical Leadership Fellow here with Healthcare Improvement Scotland, and the Chief Medical Officer, Catherine Calderwood. And this is Jill's last day actually with Healthcare Improvement Scotland, so a good opportunity to give a shout out to Jill. She's been supporting us with QI Connect throughout the year as well. Well, also a big shout out to Graham McKenzie. Graham is a consultant in public health in NHS Lothian in Edinburgh, and Graham will be our key questioner today, and we'll hear from Graham a bit later on in the call. Many of you will know Graham from his very active Twitter social media account. Welcome, Graham. And remember, please, tweet as you learn. We've got a great reach now with QI Connect. So hashtag HIS QI Connect, spread the word as we are going through. So with all those introductions, let me bring you on to today's speaker. Our QI Connect speaker today joins us from the West Coast of America. She has more than 25 years of healthcare experience, starting out as a registered nurse. She now also holds master's degrees from the University of California, San Francisco, and also a master's in public health from Harvard University, as well as a teaching position at the University of California, Berkeley School of Public Health. However, she keeps her feet firmly on the ground and is a committed advocate of citizen, patient, family and staff involvement in the way that health and social care services are provided. Anna Roth is the Chief Executive of Contra Costa Regional Medical Center in California and is deeply involved in supporting and promoting patient safety and quality improvement in American healthcare through an impressive array of high-profile board and committee appointments. I first met Anna 10 years ago when we were both Quality Improvement Fellows with the IHI in Cambridge, Massachusetts. Over the years since then, Anna's passion for joining systems up around people, her energy for change, and her advocacy of the underserved has stimulated many others to do the same, helping many, many people and families along the way. So welcome and good afternoon, Anna.
Thank you. I'm so excited to join you all today. Brian has agreed to help me because I'm joining you all with a little bit of technology hampering here. So Brian will be advancing the slides for me. So I just want to say thank you so much to Health Improvement Scotland and QI Connect for inviting me to join you today. As Brian said, I'm on the West Coast, so it's early morning here. I don't have my QI Connect mug, Stuart, and if I could have hit my arrow, I think I might have won. So Stuart, I'm sort of longing for that mug, so congratulations for winning the competition. I think that's a great opportunity. Now I'm going to have to join next week, and I'll be competing with all of you. As Brian said, I am the CEO of Contra Costa Regional Medical Center and Health Centers, which is a county health delivery system in the San Francisco Bay Area. I also run for the county the detention health services, so that is the jail-based healthcare operation. We are a public health system, meaning very much like some of the other countries on today, we are a government-owned and operated health system, which is sort of an anomaly in U.S. healthcare. And I've been here since 1993, so I'm approaching my 25th year in this particular health system. I wanted to, Brian, maybe you could advance a slide. I want to talk today a little bit about, I sort of told you who we are. I also want to talk about how we kind of view health, which is sort of an interesting topic. If you're following along U.S. healthcare and the discussion, I think it's sort of an apt topic. I think it's interesting that we're sort of having that basic discussion, but I think it's worth discussing because as we've sort of learned here in the U.S., sort of underneath the surface, I think the confusion around this is causing a lot of challenges for those of us who are really interested in advancing health across the population. I hope to talk about today a couple of, I think, promising pilots that we're doing, as well as sort of how we're moving those to scale. And then I'm sort of planning to leave some time so we can talk about sort of your work, your vision, your ideas, and your promise to your community. So Brian, if you could advance the slide. So I wanted to ask this question, sort of, what is health? And as we think about this, I think that a lot of people are approaching this in a variety of ways. I know that Scotland has been asking a lot about what matters to you, and I think we're inspired by that as well. As we think about health, I think it's a very personal question. And so how does a health system understand how to engage with people very personally like that and really do that at scale, but also consider sort of the health of the entire population? And I think if you asked me, you know, if you asked, as we asked our professionals, we think about health as, you know, we use indicators like the health maintenance indicators. How many health screenings have you gotten? Your even life expectancy and age. I mean, we have a lot of blunt sort of indicators on what is health. But if we really start to ask people what health is, those answers may be very different. For me, health may be the opportunity to have coffee with my mother in the morning, or to be able to watch my child run at his track meet. And it may not look the same for you. And so I think that as a health system and as a leader of a health system, sort of we're challenged every day to figure out how do we design systems to understand the answer to this question deeply on an individual level. Then how do we create a care experience that honors that? And then also, how do we sort of advance health across a geographical span, you know, whether it be a county, a city, a neighborhood, a country. how do we really do that? And I think it's, it's a challenge to strike a balance to really move from sort of individualized care to care at scale and health at scale. For the purposes of our talk today, we'll just sort of I would like to accept sort of an international sort of view on health. So Brian, if you could, I think, hit the button one more time. I think that, oh, you guys were looking at, I'm sorry, Brian, you're doing this on a PDF, aren't you? Are you doing this on a PDF, Brian?
Oh, sorry, just for you, Anna. Everyone else has it on slides, yeah.
So are you guys looking at health as a state of complete physical, mental, and social well-being, or are you looking at the U.S. map?
Oh, the U.S. map, yeah.
Okay. All right. Well, let me just sort of summarize then the last slide, which I'm sorry some of the animations aren't going to carry over, that health, for the purposes of my talk today, we're going to really view health as we're going to accept World Health Organization's definition and view health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So Brian sort of put up the map here, and I put this up here because I can't go through this talk this week or even at this time period and not sort of address, I think, what's happening in the U.S., which is, I think, an illustration of kind of the challenges we're facing across the world, which is there is not agreement on how to really approach healthcare in the U.S. And, we envy many of the developed nations that are on the phone today, and even many of the nations that may not view themselves as developed nations. We really envy you that you see healthcare as a right. And in our country, I think this electoral map is just sort of an illustration to illustrate the level of, I think, still confusion and lack of clarity on who deserves health, where the base, really is for who gets health care. And I think it's also a reflection of just the deep, deep differences in belief systems within a society. And so I think that is, whether I like it or not, certainly that is the context in which I operate. And I think the reality is, to some degree, that's the context in which we all operate. And so how do we work in this divided context and address health at the population level if we don't have the luxury of agreement? And I think to some degree that sort of plays out all the way, into from a nation to a state or a province or a territory to a county, to a city, to a neighborhood. This, and this is sort of played out kind of this what is health and how do we address health internationally. I want to give you, kind of take you away from America, and to the next slide, we can sort of see this international view, which is really, this is based on Bradley's work, which is showing on the green graph is really, the green line on this histogram is really life. And the red and the blue lines are showing the difference in healthcare and social service investment. And as you can see, the United States, the blue, the dark blue, they have a heavier weighting on investing in health care proper, and the red line really is showing that in some other nations, their distribution of investment is different, and that is based on, values. I mean, if their electoral map were to be put up, it might look very different than the United States. So just to say that this different view on how we see health, the different view on how we see investing in health carried out across the world. The one other sort of, I think, thing about this map is that the total investment actually is not as different as some of us may think. It's just the way you're spending your money. And what we see is that the nations who are spending more money, that are distributing more money to social services, are in fact getting more years of life for their population. So I think for us, the implication of this is really to understand deeply how we are going to work in this context, and as a health system, what do we use to sort of drive change? And for us, as we go to the next slide, which, again, I'm apologizing because it has some animation built into it, so it's going to look confusing to all of you. We really we think about what is our purpose, and I think that's very familiar to everybody. We kind of look through the lens of our mission, and we think about what is the purpose of our system. You know, for Contra Costa, you know, our purpose of our system is really to produce health for everyone in Contra Costa County, with a special emphasis or special design emphasis around those most vulnerable. We are the only health system for the underserved or uninsured or the poor in our region. There are many other health systems operating in this region, but our unique purpose is to make sure that nobody in Contra Costa County is left out of the opportunity to experience health. I think if we look a little bit deeper at this, we sort of shift from thinking about our purpose to what is our promise to each citizen in this region. And when we think through that lens, it really sort of pushes us to figure out how to understand this first sort of question. I think the question that Scotland has been asking, which is sort of what matters to you? And I think that's a little bit different than our purpose. And for us, as we look through the lens of our promise, which means you will not be alone, we will stay with you, we will do whatever we have to do to understand deeply what it is that you're facing every day. That sort of changes the conversation. Our purpose is really to produce health. Our promise is really to eliminate suffering. And so as we sort of look through that lens, for us, it sort of took us to thinking about how do we get the entire health economy together and drive change across a region, which for us, that prompted us to use something that's very similar to many of you, which is a collaborative process, a breakthrough series collaborative, where we started to create large-scale learning sessions across public sector and bringing people together to learn together. We brought people from law enforcement, from healthcare proper, from public health, policy, elected officials, education leaders, and frontline staff, and most importantly, citizens from our community together, and have gone on a multi-year journey with them in large-scale learning sessions to learn about improvement, to learn about design, and really to learn about each other. And I want to just share with you one story from that. If you could advance the slide, Brian. I want to share this story of a woman, Claudine, who I met at one of these learning sessions. And there was several hundred people at this learning session, so this could be really intimidating for citizens. But as we heard Claudine's story, I felt like it was worthy of sharing, and she was really honored that I would share it with you all today. And what I learned about Claudine is that she spent most of her life in a housing vulnerable situation, or homeless in our community. She also fought with or faced chronic mental health issues as well as substance abuse issues. She had a history of marginal employment, also leading to mostly unemployment, and she had a series of episodic encounters with our healthcare system, our legal system, our judicial system, our jail system. And so Claudine was just sort of moving through all of the different sort of branches of public sector and truly experiencing what I would call a lot of needless suffering, and we were just sort of near missing. Many people might call a person like Claudine a high utilizer, and certainly she was. We were seeing her a lot. The ambulance drivers knew her, the police knew her, the emergency departments knew her, and so on. And what happened was Claudine met with one of our community leaders, a mother who actually, her son was institutionalized, but she had, for mental health reasons, but she has become a strong advocate in the community. And this mother and Claudine connected, and this mother started to work with Claudine, and the mother happened to be on the Contra Costa Regional Medical Center's executive team. We years ago, opened up our executive team and invited one community member and one patient and one family member to have permanent seats on our executive team, and their constituents nominate and vote for who takes those seats up. The executive team does not get to cherry pick. And this woman was on our executive team and started to talk with Claudine. And she really drove sort of bringing the different sectors of public sector together. She sort of went and knocked on everybody's door and said, you know, you're in charge of Claudine's primary care. I'd like to talk with you. You're in charge of the police that work in the community that Claudine is, you know, living in. I'd like to talk to you. And eventually she met a core team of people who were really working with Claudine on a regular basis but didn't know each other. How I sort of met this team is at our COCO 2020 learning session, Claudine now was sitting up leading a panel where she had been housed now permanently. She had permanent housing for the last 2 years. She had her dog, which, as you can see, who is really filled her life with joy. She is able to successfully address her substance abuse and mental health issues, and she has her chronic medical conditions are now sort of under control, and she is experiencing joy in our community in ways that she never thought was possible. She was flanked on this panel with her entire multidisciplinary, multi-sector team. And she talked about how each one of these people really seemed to, from her position, make an exception to the bureaucratic barriers that were in the way previously. So this team started to work in exceptional ways for Claudine and connect to each other and come up with a treatment plan that resulted in optimal health for Claudine. One of the things that was a barrier is Claudine had her dog, and in order to go into treatment, she actually needed a long-term babysitter or dog sitter for her dog, and her mental health case manager was able to secure that. That happened to be the biggest barrier, actually, on reflection to her, was this care for her dog while she went to take care of herself. So this is just sort of an example of, for me, which was a moment of curiosity. So I asked Claudine in this room, Claudine, tell us what it would look like if you had one wish, you could wave a magic wand, and to tell all of us that are in these cross-sector leaders, what would your wish be? And she said, if I had one wish, it would be that every person had a special team like mine that was working on behalf of them and helping them overcome the barriers that they face. And so that was really the design principle now that the team started working up against, is how do we create this kind of individualized experience, and how do we overcome ourselves and bring teams together that may be working across sector? How do we do that reliably every time for every patient that needs it? And not everybody will need the level of intervention Claudine needed, but if they do, how will we know, and how will we then mobilize around that? And that really became the call for action for us. As we started thinking about this, sort of the next thing we thought about is, how do we even know what matters to the patient? And I think Scotland just did in June a sort of What Matters to You Day. We started to do that every day in the clinics. And one of the things we asked the patients is, tell us the top 5 things, the most important barriers you're facing to experiencing health. And we had some predictions. And our predictions were really, we thought that they would say things like chronic conditions like, you know, asthma, COPD, or even access to an appointment. Those were we thought maybe some might say obesity. You know, those were the kind of things that providers and the system, those were the answers the system was generating. But when we went out and asked the patients, we got a very different answer. And Brian, maybe you can advance the slide for me. The answer that the patients told us, these were patients sitting in our waiting rooms across our system. 62% of them, actually nobody said, you know, asthma, diabetes, COPD, you know, all of the things that if you went into a room of your providers today and asked them what the population is really facing, these are the, I think I'm gonna guess, these are the answers you're gonna get. Actually, what the patient said is, we don't have access to food. We don't have housing or stable housing. We don't have jobs. Some of them have jobs, but many in the United States, many don't have jobs that provide health care benefits, and that is significant in the U.S. As you know, if you're watching sort of from a distance or you're here in the U.S., you know that that is not, that is an important feature of employment because we do not have government-provided health care. So, you know, half of them said, I don't have stable access to energy to keep my refrigerator on. So when you start to look at a list like this and you're a health system, this is really a wake-up call, knowing so many people, so many of our population are facing things like diabetes, and when we know that they do not, 62% of the people do not have access to nutritious food, or half of the people may not have power to their refrigerator to keep their insulin refrigerated. These are major design challenges. So we really set out in one of our clinics where we sort of saw the highest burden of these kinds of issues. We set out to pilot addressing social needs across the population that was using that clinic. And we partnered with an organization called Health Leads, and we started to administer social needs screenings for every person that came into the clinic. And if you could advance the slide, Brian, for those of you that are keeping score, I think it's really important to understand what the results of these pilots are. Our social needs screening resulted in us having a much deeper understanding of what the population needed. We put in a measurement system that really was a 1 or a 0. If you met the person's need, you got a 1. If you didn't, it was 0. So a referral didn't count. The referral had to lead to the actual resource. So in other words, giving somebody a slip to the food food kitchen or the food stamps was not enough. We had to confirm they actually got food in order to actually give ourselves, you know, sort of a point, if you will. So what we found is 50% of the people using that clinic actually had some sort of a social need. The breathtaking data, because this actually is only one nursing station in one clinic in 1 year, where we touched over 8,700 lives. We made almost 4,000 resource connections, and half of the people moving through that nurses station had a social needs screen. And when you start to think about that at scale, those are pretty daunting pieces of data. They're also very promising pieces of data because what it showed is that we can actually, as a health system, actually get food to people. We can actually get energy supplements to people. We just have to design the system to do so. So I think, though, as I, you know, sort of now as I'm, you know, as we started thinking about this and thinking about the scale of the problem that we were facing, we really needed to start thinking through design, this lens of design, and kind of where do we start? And I think as you are all thinking about this and you think about your health system and the community or the reach or scale your health system is really facing, it can be extremely daunting. And I think that for us, that sort of brought us back to the promise. of our system, and sort of how do we kind of segment this out with design science, and where do we start? And I think that's a really important feature of your improvement work, is like understanding where will you start and then getting started. And at Cincinnati Children's, they sort of say start before you feel ready. And so I think it's important to get to this, to the answer of this question right away. For us, as we look through the lens of our mission, it became clear where we needed to start. And for us, we needed to start with those who were the most vulnerable in our community. And maybe you could advance the slide, Brian. And for us, that meant that we needed to start with the people who were returning citizens who were incarcerated in our detention facilities. We know, looking at the data, and these kinds of studies are repeated across our country, that people who are being released from incarceration have 12 times the increased risk of death in the first 2 weeks after release, and even 2 years later, they still are have 3 times higher risk of dying than their counterparts who were not incarcerated. So we started to design systems that addressed, and especially clinics that were specifically for this population. We put conductors, people who had been incarcerated before, so peers, went in, are starting to go in and do social needs assessments of people during the release process from jail, so that there is a seamless sort of handoff into a specialty clinic for these people, and they see people they trust, and they see people who understand them. In the next slide, we also started working with foster children. We know that this group is at very high risk and very vulnerable for suffering, for adverse events, and many of them moving multiple times in 1 year. This is a group that has extreme challenges around continuity, not only continuity of health care, continuity, period, in their life, setting them up for many challenging issues. This is another group we started to design around. We started to reach out to and create specialty streams of care for this particular group. One of the foster mothers that was at our Contra Costa 2020 session, reminded all of us that we have to collaborate and that no one has all the answers. If you can go to the next slide, Brian, the next group that we address and we are working to design around is the homeless population. And in the United States, over 500,000 people are homeless, and of them, 1/4 of them are children. We also know that over half of them are over 50 years old. And if you're not 65 in the United States, you probably don't qualify. If you're between 18 and 65, you don't necessarily qualify for health care. So we started to design outreach programs, partnering with law enforcement, and really creating options for these people. One of the things we discovered as we started looking at these groups of people is often the first contact with public sector is law enforcement, and many times they are actually being dispatched out for a unmet social need that really sort of escalates into a crisis. The officers are then faced with very few choices. One is to send them to the medical emergency room, and I know many of you, your emergency rooms have these people in them often. One of them is to arrest them. One of them is to put them on a emergency psychiatric hold and send them to your emergency psychiatric facility. And then finally, and one of the most burdensome for even the officers, is to walk away and hope and pray that everything's going to be okay. And what we wanted to do as a health system is create more options that would lead toward health rather than sort of exacerbate the social need. The next slide, we sort of harnessed in this next slide, we sort of reached out to the community, and we reached out to the promotoras, which are, in our community, we have a very high population of immigrants from South America and Latin America, and we actually reached out to the promotoras, which are they are our community or cultural brokers into the Latino community. We also reached out to the African American community and created health conductors, and these are really peers that are working in really powerful ways to help us connect directly with this group of people. And I think, you know, we put up there sort of an array, some of the outputs of these individuals, and I think the most powerful output of these individuals, though, is creating a real, authentic connection between the health system and vulnerable populations or the population or citizens in our community. And I think that that is something that is a challenge for health systems. We're not designed to really connect in a meaningful way with the community, and I think we will not be able to advance health if we aren't able to do that. I know that next week that you guys are going to be hearing from, or the next session, I think, of QI Connect, you'll be hearing from Brene Brown. I find her, you know, extremely inspiring, and actually we designed, one of our design principles is really around her principle, which is, if you can advance the slide, Brian, which is really that connection is so important, and the absence of love, belonging, and connection will always lead to suffering. And we, you know, really took that Brene Brown sort of concept to heart as we designed, and we hope that when you look at our programs, you see this sort of, you know, connection, and those programs that I just kind of sprinted through are really designed to do that, to create a meaningful connection with those that we serve. Our kind of next steps now, these are a series of kind of pilots. The next steps that we're taking, which is on the next slide, we are now working on something called Community Connect, where in partnership with our public health department, we are sort of moving in 14,000 people a year where we are trying to create this authentic connection in what would be what I can only call, you know, really a social HMO, or a social needs health plan, if you will. We will be looking at the working with specifically sort of high-intensity case management with the 4,000 those at highest risk in our community, and then using sort of a utilization data from law enforcement, homeless, and other public sector. We've come up with sort of an algorithm to identify the next 10,000 that are really at risk for moving into this high-risk population, sort of moving our intervention upstream and really kind of reaching out to them before, you know, that crisis encounter. And we sort of anticipate over the next 5 years, this program will touch about 60,000 highest risk and rising risk members of our community. And, you know, that said, they'll be moving sort of through that will have some turnover, because we know that people will progress and people will get better. So just wanted to give you kind of, next slide, Brian, and I can kind of give you a snapshot of kind of what I've just walked you through, which is really sort of how we kind of started a few years ago with sort of one desk in one clinic in one part of our county, and how we're sort of moving out to the population across Contra Costa County to really end the suffering, and how we're leveraging the entire, all of our public sector partners, and most importantly, the community to really produce health. On the next slide, I just summarized to you sort of how we are, you know, how we've approached pursuing our promise, which is we have found a place to start, which for us, that's through the lens of our mission, and that was with the most vulnerable. Understand what matters to them. We actually didn't add resources, we've just realigned them, so we use smart realignment, And even though we started with pilots, we always remembered the end game, which is really our commitment to the community as a whole, to the region as a whole, so we designed for scale. And then bringing our staff together, very much like we're all together today, and the leaders in the system giving the staff permission to be brilliant, liberate them from the bureaucracy, let them know that it's okay to sort of think beyond the current boundaries. And I just kind of wanted to leave you, before we kind of go into our discussion, I want to leave you with sort of a thought that I have, or an inspiration that I had. I had the opportunity to see Captain Scott Kelly a few years ago at the IHI. He's actually spent a year in space, and for those of you who are on Twitter, which I think most of you are, this is a very technology-savvy group, I can see by my Twitter right now. If you have the chance, you should go to his Twitter. He has the most incredible photos that he sent over his year in space, sort of taking pictures of us back down on Earth. He's just incredible pictures. But one of the things that I think that he said that I was struck with was he said, before he spent this time in space and before his journey as an astronaut, he used to think that the sky was the limit. And Brian, if you could advance the slide, after his year in space and being able to sort of look down on us, he actually has come to realize the sky is not the limit. And so I think I want to leave you with, I think that we are accepting imposed boundaries, and I would just encourage you to share your ideas, to challenge the limits within your system, and to give your staff the permission to sort of push beyond the sky and pursue your promise. And I just so appreciate having this time to talk with you today, and I'd love to open it up now to hear any comments or questions. I can't actually see the chat box, so maybe Brian can moderate that for me, and I'm excited to continue the discussion.
Anna, that was absolutely astounding, really brilliant. The chat box, like Twitter, has just gone mad in the last half hour. Really quite amazing. We're going to start the questions while I take another look at the chat box. So we start the questions with Graham. Graham, welcome onto the call.
Hi, good. Hello. Can you hear me okay?
You're very clear. Graham, you and Anna met just before the call. Graham, what do you think of Anna's talk, and what's your question for Anna?
Well, I'll give you a few reflections. I thought it was a very powerful talk. Indeed, it was great to hear reflections on the importance of the social determinants of health, hearing about things like poverty, housing, employment, and also having some very pertinent reflections on the more severe manifestations of that. We heard about prison health and homelessness, and obviously in the UK and in the US, I think there's a lot of talk at the moment about adverse childhood experiences, and so it was all very, very pertinent and very timely. Something that we think about with America and the UK at the moment is a breakdown in trust as well with the health system, and you can see that in things like, well, if you look at social media discussions around immunization, climate change, if you listen to Donald Trump about any of these topics, and more recently in the UK with the Great Ormond Street case of Charlie Gard and how that's been covered in the mainstream press. Thinking about the reasons for that breakdown in trust, inequalities and poverty and the rise of populism seem to be quite important in that. And so my question, well, I'll start off. Do patients and the public need their basic needs to be met before thinking about their own and others' health? And that's a thought, but building on Anna's direct experience there with addressing food poverty and energy poverty, did she find that if doctors and nurses started by addressing social determinants of health, so food and energy here, did that help restore the trust in the health service? And did you see people taking up the more kind of conventional health interventions as a result?
That's a great question, Graham. And I don't know that we have the definitive answer to that, but we believe, and this is sort of in the sort of recognizing that there are some things that need to be believed before they can be seen. And I think that's sort of a really important, and I think counterintuitive statement that I'm saying, because I'm not sort of trying to avoid data. I'm trying to say that I don't think the system is designed to measure, to get at the answer to your question quite yet, but I do think we can get there. One of the things I would just say is this is, this was part of the striking this balance, is it, does a health system, many people, would say, you're a health system, your job is to focus on health care and not necessarily basic needs. And I would say back to that is you haven't been in your exam rooms lately or your waiting rooms, or you wouldn't say that, because what we found, and I think, when we talk about trust, we talk about the patients, we also need to talk about the workers and the workforce, whether they trust the institution themselves. I mean, I think that, workers are fatigued, they're tired. If you go into the exam room, any primary care doctor, and frankly, any doctor, nurse or care provider in these environments are facing a tidal wave of these kinds of needs rushing at them. Many are so stressful and so burdensome because they're working in a system that's not designed to address it, that they actually, I think it's a prevailing practice to practice that don't ask, don't tell, because it's too stressful to know people are suffering of hunger and you can't do anything about it. And when we introduced this social needs interventions into our clinics, and we started to bring back the data to the doctors to say, you wrote, 20 prescriptions for food. Of those 20 prescriptions, somebody else that you can now trust has been working on those prescriptions, and 16 of those families got food. When we started to present those data to the care providers and the care team, people became overcome with emotion. I mean, so it's not just about the community trusting us, which I think this will do. It's also about our own workers, recognizing the disrespectful environment they've been working in. They are facing these social needs in every exam room across our country and across the world, indeed. They are actually having these conversations with their patients, or sometimes they're not, but they know it's right underneath the surface. And we've burdened them with hanging on to that without actually acknowledging that. And so as we start, I know as I sit here today, even though I can't, give you the data, the trust indicator or the trust index, and show that we've raised, if I were to go to the clinic today and say to the providers, well, gee, we don't exactly know if this is working, so we're going to stop doing it, there would be a revolt. They feel honored and acknowledged by our system really building this in, and the relief that they feel that they can now do their job. And if they come across a housing or a food insecurity, they can write a prescription for that, and they know there's a system now in place to address that. That has been an extremely powerful sort of output of this intervention.
Excellent. And that's our experience as well in Scotland. We have an equivalent of your food stamps program, a thing called Healthy Start in the UK. And when we started to talk to pregnant women about that and through their midwife, we started to talk about benefits and refer to welfare rights advisors. And we found for the women referred, there were £4,000 UK pounds sterling that hadn't been claimed correctly for these families per family, and that made a huge impact on their finances and hopefully on their health and well-being. But like you, we can't evidence that. So, evidence the impact on for example, their ongoing uptake of antenatal care or the health of their children is a very difficult thing to do. But thank you, that was a great answer. I'll let others take questions now. Sorry.
Thank you very much. Thanks, Graham. Just a few comments from the chat. Jill Madden, who's a Service Development Manager of Voluntary Action in North Lanarkshire. Jill says that as a former health visitor in a deprived community, if I could have sorted out families' housing issues, I would have sorted out a lot of their perceived or real health issues. just reminding us of the contribution of the determinants of health. Let's just take another question here. So 3 points. So Jenny Pennycook, who's a practice development facilitator at the Beatson Cancer Centre, Jenny says, how do we continue to encourage our staff to be brilliant when so many management structures stop innovation due to scrutiny? And Fiona Cameron, who's the head of service in NHS Lothian, follows on the same point to say that it's not just scrutiny that prevents staff striving to be brilliant. It's also about our capacity and need to stop doing things that don't work, don't make life better, or make things safer. And just following up on that again, Lisa McKenzie, who's a fellow with the IHI, goes to the same point and says she loves the concept about supporting staff to challenge the boundaries to provide truly brilliant services. It would be interesting to hear a bit more about the strategies that Anna used to engage and empower her staff. So that's all about engaging and empowering your staff, Anna.
Yeah, I mean, I think that these are all great points, and you know, we haven't nailed it. You know, I come to you humbly saying we're working on this. I think part of it is for us, we've used improvement science. We actually have a variety of investments in the staff to sort of teach them about improvement, and I think improvement by design promotes an respectful introspective process. The other thing is, you know, we've truly made key high-level leadership appointments. We've really thought about, we've looked for attributes like curiosity. So when somebody comes to me and says, I think something's, you know, not right with the system, or I'm running into a problem, or they come to another one of the executives in our system, we've really worked a lot on how to embrace this as a, you know, a design challenge and not defend the system. I mean, you know, and I think if we're really being honest, we all understand the system is flawed. And so I think that we have worked on even making hires based on sort of a curiosity quotient. That is challenging to do in a civil service sector, but it can be done. And I think the other thing is wherever you are, whatever point you are in your organization, lead from the front. So it begins with you, and you need to practice this behavior when somebody brings something up, even if they bring it up in a provocative way. It's really how you meet that challenge. And I think if the leaders are visibly open and curious, it will start to spread and be pulled through the system. And this is not something that can be changed by a memo. This is behavioral change that has to be modeled from the top and has to be taught. And it is a part of what we teach in each session at Contra Costa 2020 is, you know, you have to put your money where your mouth is on this, and people have to, you have to earn the right to call your system safe. And even with that, you will have breaches, and you will have times when you don't hit the mark, and then you have to go back, you have to own it, and you have to work your way out of that.
Anna, thank you so much. We're coming to the top of the hour just now. Just some comments that were coming through. So Lorna Darry, who's a specialist lead at NHS Education Scotland, was just reminding us of the non-clinical staff, what she referred to as the invisible staff. And I know that your organisation goes across all staff, as you've said, from the top of the executive or C-suite all the way across to the porters and the support staff, right?
Yes.
In terms of involving all of them, of course. And many contributors in the chat were talking about how impressive it is that you've managed to get various organisations to work together. And Jill Madden, Service Development Manager from Voluntary Action Lanarkshire, and also Wendy Copeland-Blair, from Merseyside NHS Foundation Trust. We're also impressed with how you're bringing various parts of the system together. Anna, it's been a great call. We had some comments early on in the call from a colleague, Miraj Patel from the USA, and you know, some of those comments were just reminding us of how we perhaps take some of the basics of access to healthcare for granted here in the UK. and you're doing a great job over there in your part of the USA, trying to make sure that people have access to health and healthcare. So Anna, it's come to the end of the hour just now. I'd like to thank you on behalf of QI Connect and from all the organisations that join us and for your team. Just to remind everyone that the QI Connect sessions continue next month. As Anna said, we have Brenny Brown joining the lineup. We're coming just past halfway in our amazing 2017 lineup. And Brenny Brown is well known internationally for her work on empathy and human understanding and holds a research chair in the University of Houston. So we look forward to hearing from her next month. Remember, follow us on Twitter, and I look forward to speaking with you all next month. And thanks to the whole team here for making a great session today. Thank you and goodbye.
Thank you.